Maybe we can wait for a couple of minutes before we start. Okay, we have 10 people. Can we start, Asmita?
Yes, ma'am, we can start.
Okay. Good evening, everyone. On the behalf of IA and Geriatric Neurology subsection, I invite all of you for this guest lecture by Dr. Amit Batla. So I consider Amit Batla sir to be like one of my very close seniors and colleagues. I have seen him and I have grown up looking at his achievements and reading through his seminars. That's how I crossed my neurology training. So it is indeed my pleasure to introduce to all of you Dr. Amit Batla, who is an honorary clinical associate professor at the Queen Square Institute of Neurology. He is the education committee lead in the Association of British Neurologists, and he has a lot of accolades to his credit. And the floor is all yours, sir. Welcome.
Thank you. Thanks for the nice introduction, Ella. And I hope people find this useful because this is the time of the day in India where I'm sure you it's not as sunny as it is at the moment in UK. So I'm sure you're having some preparations for dinner as well. So I hope I can share my screen now. And Ella, just confirm you can see it all right.
Yes.
Are you able to see it? Yeah, perfect. So thank you. I've been given a difficult task, I would say, to talk about management of urogenital issues in Parkinson's disease in older adults. Now, I do have some experience of working in this field, and I'll try my best to give you some very practical tips and advice on how we can do this. These are my disclosures, non-relevant to the session today. So let me just ask you first, I mean, the people who joined in this meeting, do your patients with neurodegeneration and Parkinsonism have urinary or sexual symptoms? So I'm sure you will possibly be seeing quite a few of these people. And in your experience, do you think it is common? Do you think it's due to the Parkinson's, or do you think it is just general degeneration with age? Or do you think it is specific to certain kinds of degeneration? For example, is this sometimes a diagnostic clue, like in MSA? And one of the big questions that by disclosure, I'm a neurologist and a movement disorder specialist, so I don't work in neurology. So one of the questions we often have for ourselves is this my problem? Because I have to manage the patient's Parkinson's, and there's so many things within Parkinson's to manage. Why should I bother to ask about bladder and sexual function? And maybe this is someone else's job. And I hope that by the end of this session, you will feel more aligned with what I think is important for us to do, even if you're working in a busy neurology clinic. So first of all, the first question I asked was, is it common? Yes, it is common. And I think you possibly know this, but how common? I don't have obviously data from India at the moment, but from what I know from the NHS data, which is a very good way of data collection, is that people who get non-elective admissions, which means emergency admissions where people would be presenting to the hospital emergency and be admitted, out of them, for people with Parkinson's disease, UTI is one of the leading causes. And if you join and combine the UTI with other genitourinary and renal disorders, it becomes one of the commonest reasons for admission to emergency. And that is highlighted in some other studies as well, where bladder problems is a top cause for non-elective admissions, and particularly in elderly population with Parkinson's. So I think one of the things that is very clear is you cannot ignore urinary symptoms just because you're not a specialist, because even if you're looking after their Parkinson's, maybe it is the urinary problems that are leading to the hospital, but at the end, you will end up managing those. And from our experience with working with Parkinson's, I'm sure you will agree that everybody who comes in with a bladder infection does not have a very good outcome at the end. I mean, they'll go home worse than they came, and some of them might actually never go home because they might just get sepsis from there. And there's a risk of mortality with this as well. So if we could do anything to prevent it, I think we should. So I'll give you a couple of case scenarios. So first is a 76-year-old female. This is a real case. So she was diagnosed with Parkinson's 5 years ago, has hypertension and diabetes, has a complex treatment regime because of diabetes and hypertension, as well as been on coca-levodopa 3 times a day, 250 and 250 at bedtime. She's also on rasagiline, telmisartan, metformin, atorvastatin, and takes insulin as well. I didn't mention that here. Fairly active. Otherwise, she was doing well with Parkinson's. But then within the last 2 years, she's developed progressive incontinence of urine. And what happened was that she was going to the toilet last month and had a fall, which led her to the hospital admission. So 2 falls happened in the last month, but one of them actually led to the hospitalization. And she actually broke the neck of femur. So it didn't help the situation at all. I want to think about a second situation where this is a 64-year-old male, a bit younger for you, some of you, but still quite old, diagnosed with Parkinson's in 2 years. Again, just simple coca-levodopa, doing well, not had too many problems with the Parkinson's kind of things, but developed orthostatic hypotension and passed out. So he has hypertension, so we've not been able to increase his coca-levodopa much. And he's also getting impaired mobility. He's not able to walk very well. And then within the 6 months, in the last 6 months, although the Parkinson's diagnosis was 2 years ago, 6 months, he's developed poor stream and a history of frequency and hesitancy. So possibly developing some retention. But what happened to both of these situations is when they came to the hospital, they were both prescribed maribegron, 25 milligrams by the neurologist, which is very common. I mean, you see someone with Parkinson's, you don't have time to talk about anything further. You give them maribegron and you expect everything to work, which is not an uncommon situation. But we'll come out the other end of this talk possibly thinking differently, because I don't think this was a good option for either of these. So from the pathophysiology perspective, let me just take you through very briefly. I'm not going to talk too much about this part, but I think what is very important for us is the bladder is a stop and go mechanism. There is a way to control urine and there's a way to go to the toilet. So there's a way of a pontine storage center, and then there's a micturition center. Both are located in pons, very much near the periaqueductal grave for the micturition center. And what they do is they have to keep the bladder in a storage phase, and then there is an active phase where they actually release the urine. And in the brain, there are studies that focus on what are the areas that are activated during resting phase and what are the areas activated during micturition, and they're obviously different areas. But as you know, in terms of management, what we're more concerned about is the control that is cholinergic and adrenergic. And antimuscarinics, which are commonly used, act on the cholinergic control, and they block the receptors in the bladder, so they inhibit the voluntary contractions of the bladder and help with retaining more urine, whereas the other aspect is increasing the relaxation and allowing more urine to accumulate in the bladder, both of them helping with incontinence, as you can imagine. So what we do on a regular basis, and this is more focused on not just clinical practice, but let's say academic settings, and I'm sure because Dr. Ella works in AIMS, when you see someone in AIMS with the bladder problems, are there any elements within the Parkinson's assessment that help us? In the MSA, there is UMSARS, and in Parkinson's, we use UPDRS. These are the rating scales that we commonly use in practice when we come to monitor Parkinson's patients and MSA patients. For the MSA, there's UMSARS. And there's also a non-motor rating scale. So within the MDS UPDRS, which is a scale that we use for assessment of Parkinson's, there's not much actually. In the whole of the MDS UPDRS, there's only one item that talks about urinary problems. And I think this is underrepresented in that. But thankfully, there is this MDS non-motor rating scale, which is a bit better. And I think it covers pretty well the aspects of urinary and sexual involvement in Parkinson's, which I think I would like to cover in somebody. So it's a good guide. I'm not saying you need to use these scales in every patient in clinic, but it's a good guide to what questions you should be looking for and what questions you should ask. So what they ask in the MDS non-motor rating scale is about urinary urgency, and they want to have a frequency and severity of that, urinary frequency, nocturia, which is the nighttime score of how many times you go to the toilet, for example. And in the sexual business, they ask about sex drive or interest, sexual arousal or performance, and they do the frequency and severity and a total of it. And I think this is a useful scale in terms of understanding what questions we need to ask the patients in the clinic, and even if you're not using this scale for clinical assessment. But a clinical assessment can be a bit better than just these three items. So practically, as I mentioned, the biggest history that I want from somebody when you're asking somebody with a bladder symptoms is, do they have storage symptoms or do they have voiding symptoms? So in terms of the storage symptoms, which is where the storage mechanisms of bladder are failing, they can have more frequency, they can have nocturia, they can have urgency, meaning when they've got to go, they've got to rush. And then there is normal or reduced sensation of bladder filling. And then, of course, there's incontinence, which is a sign that bladder is not able to routinely contain the volume that it used to in the past. And then there are voiding symptoms, which are slightly different, which is hesitancy, meaning can't empty fully, inability to void, straining to void, and slow stream. There's another thing called intermittency, where there's a stop-go thing that people often describe as like they just can't continue the stream. And then there are some post-micturition symptoms where once they've gone, they feel that they've not emptied. A lot of people might have mentioned to you double voiding, whereas they go to the toilet and they also have a poo. And there's also this post-micturition dribble. So after they've finished, they still continues to dribble in the underwear. So these are common symptoms. And I think it's a good checklist which can help you for clinical assessment. But what you're also interested in finding out when you're taking history from someone with bladder problems, particularly in older population with Parkinson's, is the severity and frequency. So is this your problem or not? Depends on how severe and frequent these symptoms are. If there is some problem that you think can be deferred to a urologist or somebody else to look after, that's fine. But if it is quite severe frequency, severity, and these people are not very comfortable coming to clinic appointments, you might not see them that frequently. If you don't cover this in the appointment, there's possibly nobody's going to ask them that question again. So I think it's important to understand between the nighttime and daytime symptoms, as I mentioned, nocturia, what factors help, and what has been done so far. And you might find a lot of your patients tell you that somebody already gave them myrobackground, somebody already gave them oxybutynin or solifenacin, and it didn't work. So then you're stuck with that sort of situation. What do we do then? And then there are some other things that people use. And what is more important for me is the history of recurrent urinary infections, painful urination, and hematuria. So if somebody gives you these kinds of symptoms, I think it's a red flag and you should not ignore that at all, even if it came superficially during a consultation during Parkinson's. But more actively, if we ask for these symptoms, this will help you direct the patient's query in the right direction and understand how severe this might be and how likely the patient is to end up with an emergency hospital admission. Of course, the other symptoms matter there as well. So these are from the table 5 is from the guidelines, the Neurojet guidelines that I was very lucky to be part of as well, to be honest, because I was a neurologist on this. And it was a great sort of guidelines. This is combined guidelines from the European Academy of Neurology, Federation of Autonomic Sciences, and Neuro-Urology Societies. But this is a practical guide for neurologists on assessment and treatment of neurogenic urinary and sexual symptoms, irrespective of the cause. And I think this still is valid for Parkinson's disease and all the other neurological conditions that we encounter, because these give you very good, and I think the symptom checklist is a very simple half a page thing that you can keep at sort of like a distance from you in the clinic. So just keep a list of them and make sure that you sort of, in the relevant situation, you covered all of them, or at least some of them, the top 3 at least, finding out if there are bladder symptoms and if there are storage avoiding symptoms, because this will help you manage your patients a bit better. So I already mentioned the symptoms of urgency, frequency, and nocturia for storage, and hesitancy, straining, interrupted stream, and double voiding for voiding symptoms. What is important to also remember in the females, especially in older age, there is something called stress incontinence, where when they cough or laugh, they can have stress incontinence. So that is weakness of the pelvic floor muscles, which is a slightly different symptom and possibly not related to Parkinson's, but obviously frailty is another issue that the care of elderly physicians and geriatricians face quite a lot. And very weak females that are very old, and some of them have given many, had many childbirths, etc. They're very, very likely to have stress incontinence. So this is a very different symptom. It's not neurogenic bladder. It's not due to Parkinson's, but it's worth knowing and separating that out from the other symptoms. But in the end, they all cause incontinence. Now, what is very relevant for Parkinson's is nocturia, because I'm not sure how commonly you're asking that question, but if you ask people with Parkinson's, and there's this study from the NMS Quest that was done a few years ago, and nocturia was the top symptom in people with Parkinson's disease. It's not just the most common symptom, it is also very bothersome. And as I gave you the example of the lady who fell going to the toilet, you will often hear this from people with Parkinson's, because anyway, their Parkinson's is worse at night when they've not been taking the medication. For example, the last dose was 10 o'clock and they get up at 2 o'clock to go to the toilet. Their levodopa is not working at this time and they fall. But the reason they're going to the toilet is because they've got nocturia, because they're having to get up very frequently to go to the toilet. And this is multifactorial. So I'll give you some causes of why nocturia can happen in people with Parkinson's. Of course, there's reduced functional bladder capacity, which is part of the neurogenic bladder that you get with Parkinson's. There's also detrusor overactivity that can happen, which can lead to sort of more problems, and they can't control the urine. There's reduced bladder compliance with age, as well as with the neurogenic bladder over a period of time. Then there's incomplete bladder emptying that happens as well. And then, in addition, there is something called nocturnal polyuria. Now, a lot of people who have postural hypotension or reduction in blood pressure when they stand up, and a lot of people with Parkinson's who have autonomic symptoms on top of the other symptoms, they will have more production of urine at night. So in fact, in one of the studies that we did, we found that usually you would have 2/3 of urine produced during the day and 1/3 during the night. And in people with Parkinson's, this was reversed. So not only do people with Parkinson's have reversal of the circadian rhythm when it comes to sleep, as you know, a lot of your Parkinson's patients can't sleep at night, they will also produce more urine at night. So that leads to another problem with everything else that adds up. And then, as I mentioned, the cardiovascular dysautonomia, some due to the disease itself and some due to the medication, would make it worse as well. So these circadian rhythm disturbances possibly add up to the problems that people with Parkinson's get. And of course, with other conditions like diabetes, hypertension, being on diuretics and stuff, they all add up and create lots of problems, particularly, as you will have known from your experience working with Parkinson's patients, their nighttime is much worse than their daytime. So I think it's important not to ignore that. So going forwards, how do you assess? So how do you assess the patients? I think, as I said to you, sometimes you start thinking it's not my problem. So that is the first thing I would advise you to consider changing. Is it is our problem in many ways. So don't ignore those symptoms. The second part is to assess for secondary causes. So that's an easy part for you. So for example, if you find out that the patients are reporting incontinence and they're not able to sleep at night because they have to go to the toilet again and again, it's a very easy thing to check the drugs. I mean, I've seen so many people who have been on coca-levodopa, and people have been thinking about postural hypotension and thinking of adding fludrocortisone or midodrine and stuff like that. But they've never checked that the patients have been taking spironolactone or a thiazide diuretic. So sometimes people have swelling in the legs, and amantadine is one of the drugs we use in Parkinson's that causes it. People with pedal edema, when they lie down at night, they raise their legs, and then they have the diuresis following that, and that can also lead to nighttime urinary problems. And of course, if they got additional cardiac problems, then of course that is another thing. So these are all causes that are not related to Parkinson's or neurogenic bladder, but are very much correctable by just taking a good account of the history, understanding what medication people have been given, whether they have swelling in the feet or edema, have they got any cardiac comorbidities, and are they on diuretics for either for the cardiac failure or for a pedal edema. What I put in red is perform a pelvic and genital examination. I don't think neurologists or physicians in care of elderly business would be very familiar or would prefer to do that. But at the same time, when I was talking about this to a urologist, they were of the opinion, I mean, this is basic medical school training, and everybody should know how to palpate the prostate and understand if there's a prostatic cancer and stuff like that. But at the same time, I understand not everybody has time in the clinic to be able to do that. But just want to emphasize that although this is not very commonly practiced, but this is part of your clinical examination, isn't it? I mean, if you were standing in court and saying, I didn't look at patient's prostate when they had bladder problems, it might be difficult to justify why, as a medical doctor, you couldn't do this. But of course, it's not common practice to do per rectal examination in everyone. Especially if there was symptoms, then I think particularly it's worth understanding if they're prostatic or not. And this is a simple test. I mean, people who know how to palpate prostate will tell you it's very simple and straightforward. But I think what is easier in India, I know, is just to order an ultrasound, which is much easier to get the volume of prostate. The other thing that you can do is, of course, have the urinalysis. This is very easy, as you know. It's just a dipstick test just to check if there's protein, if there's bacteria. And you don't need to do it yourself. I mean, while the patient is waiting in the waiting area, or for example, once you've seen them, a nurse can very easily take a urine sample, or whatever support you have in the clinic can very easily tell you. It's a very easy, simple test to just find out if there's bacteria or any cells in the urine, at least. So we know that there's an infection. Currently, infection is happening or something. And as I mentioned, a post-void bladder scan is something even we employ quite a lot here in the UK, although it's expensive, but it's still necessary. And you know, the one thing that we're looking for, if you're looking for bladder problems, is the post-void residual. A lot of people with Parkinson's will have a high post-void residual, and this would reflect either of the two things. One is that the bladder is not emptying itself, or there is prostate enlargement. And then, of course, you look at the prostate volume as well, and consider ultrasound of the renal tract if they had still doubts. What is very easy is to ask the patients, because some of the Parkinson's patients are very happy doing these kinds of things, like keeping a bladder diary, for example. So they like it, because if they tell you a problem and you say go back and just document it better, there's all kinds of people, and of course it depends on the literacy and stuff, but people don't mind keeping a record, particularly in the urban areas where they're very keen with their own management and they think this is a big problem. They can be entrusted to keep a diary. And some people come back with very detailed diaries, which will tell us everything about what they've eaten, what they've drank, how many times they've gone to the pee. And although this can be helpful in some ways, I think sometimes you also get to see some dopaminergic side effects through these diaries as well. And you say, this person is possibly getting too much ropinirole, and I should have asked him not to do this. But anyway. So I mentioned the basic tests. I think these are just some pictures following on what I said. So this is the basic urine dipstick, the small portable ultrasound, which is present in most of the neurology departments here. It's very easy to use. There's also a uroflow which you don't have everywhere, but of course, this is something which gives you a good idea of what kind of urinary problem you're looking at. You don't do urodynamics in every patient, and you possibly don't need it as well. But just to give you the idea, because these are the tests that your urology colleagues will be doing, and will come back to you if you send a referral to them and say this patient with Parkinson's has got bladder problems, they're very likely to ask for an ultrasound, a uroflow, and a urodynamic. So I just wanted you to familiarize yourself with what these mean and what they actually do. This is sort of like a filling catheter that records the bladder pressure catheter, and it measures the pressure of the flow. We also have done over the years sphincter EMGs, and in the Department of Neuroneurology in Queen Square, we've got Dr. Jailesh Panikkar, who's again revived this technique, if I may say. He's actually revived it in a way that it's been practiced a bit more widely in our patients. There was a lot of disrepute for this test in the past, particularly because it failed to show discrimination between Parkinson's disease and MSA. But the point is, it's not just for that. It is a very clear sign, as you use EMG in other conditions as well. It's a very clear sign of denervation. And this denervation, particularly using a sphincter EMG, is suggestive of denervation of the Onuf's nucleus, which is a very strong sign for autonomic failure. So not just for discrimination between Parkinson's and MSA, but being able to predict what kind of bladder involvement, what kind of autonomic involvement are we expecting in this person, this test can still be used and useful. So in terms of the Parkinson's, of course, I'm mainly talking about Parkinson's disease, but you know that MSA is the big elephant in the room when it comes to bladder symptoms. So There are some other atypical conditions as well, and you'll not be surprised to know that bladder symptoms are common in all of them. In fact, if you look at the prevalence of Parkinson's, it says 53 to 71%. In PSP, it is not very different, although it's less likely to talk about bladder symptoms in someone with progressive supranuclear palsy, for example. But of course, Lewy body dementia and MSA are the standalone features when it comes to prevalence of lower urinary tract symptoms. And you can get both storage and voiding symptoms. Interestingly, voiding symptoms are more common in PSP, as you can see, and in MSA compared to the others, which also reflects the overall degenerative process and the denervation that I mentioned, because what it is suggesting is that the bladder wall is becoming more lax, and the control of urine is not that good when it comes to emptying as well. And of course, with the urodynamics, what you're trying to get to is detrusor overactivity, where the detrusor is very sensitive in Parkinson's disease, and similarly in other conditions as well. And abnormal sphincter EMG, as I mentioned to you, is very commonly seen in MSA, but also in Lewy body dementia and PSP. So voiding function is something that is less common in most of the Parkinsonian conditions, but this can be very helpful. If somebody had not just incontinence, but problems with going to the toilet and they end up with retention of urine, this is a red flag for me if someone has Parkinson's disease diagnosis and end up needing a catheter, because that to me reflects that either they're having a urinary infection. If they don't have a urinary infection and they're just having voiding dysfunction, that is more likely to be MSA. And this is something that we have sort of found more and more, that because of the dyssynergia between the detrusor and the sphincter, people don't empty themselves well, and they keep retaining the urine. They don't empty themselves, they're more likely to have urinary infections. So this is sort of like a red flag, that if you see someone who's needing a catheter with Parkinson's, possibly they've got MSA or they've got an infection, or at least they're going to have recurrent urinary infection. So you have to be very, very careful about them. This is an area of research interest, so I'm just bringing that up because this is something we're doing at the moment. We're looking at the lumbosacral spinal cord in people with pure autonomic failure at the moment, and trying to find out if they would have atrophy of the Onuf's nucleus and the gray matter, and whether this can help predict the MS conversion to MSA. But of course, we've previously done this with MSA itself to show that there is atrophy of the gray matter in the lumbosacral cord, which is usually the bladder fibers and the control of the pelvic nerves, which comes from this area, to show that this is pathologically linked. So it's not just degeneration in the brain that's leading to it, it's actually the bladder involvement directly with the spinal cord involvement as well. So just a bit more about the NeuroGED. As I mentioned, these are the guidelines for practicing neurologists on the urogenital dysfunction management. This was a large group of people, 17 countries internationally, I think somebody from India as well. And management of urinary symptoms, this is a guidance from them. And I think this is the most practical management strategy that I can suggest to you. So I'll just use this algorithm to guide you through how we manage urinary symptoms. So first thing I already alluded to is the history taking. It's very, very important to know whether there's urgency, there's storage symptoms or voiding symptoms or nocturia. Urinalysis, very, very important. I think we all agreed as a group that this was one of the steps that is often missed, and very, very important not to miss, because this predicts the recurrent hospital admissions, recurrent urinary infections, and the prognosis for your Parkinson's patients as well. And then you look for UTI, as I mentioned. The other thing to be very careful about and not ignore is the nighttime symptoms. And the only way to find that out, which is a very easy way, as I mentioned, is a 3-day bladder diary. Sometimes if the patients are illiterate or can't use pen and paper, or if they can't write, of course, a family member can help them fill this as well. And what it does is all it requires is a measuring jug. So in India, I know you've got those mugs that people use for having a bath, etc. All you need to do is keep a separate mug for them, which is a measure in it. And you just need, every time they go to the toilet, they just be in the cup and or the mug, and you measure how much it is, and somebody needs to just write it down how much urine they passed. And if you do that just for 3 days, you will have an exact idea of whether it's daytime or nighttime, and how many, is it nocturnal polyuria or is it just nocturia, and it'll give you a very good, the best idea you can get about nocturia is through this 3-day diary. And these are very simple, basic things. Urinalysis that can be done everywhere. 3-day bladder diary can be done with the patients. With the blood tests, I think there's a very big red flag with the PSA. I'm sure this is not a business for most of the neurologists to be worried about PSA. PSA obviously is the prostate-specific antigen, which is a sign of prostate cancer. But of course, if you come across somebody and you just send the blood tests for them and the PSA is high and you ignore it, that's not nice. So obviously you would want to be careful if somebody is reporting with Parkinson's. A lot of things get hidden and they're not reported very well. But if you see in someone's blood reports that the PSA was high, you can't ignore it and you have to flag it up. Measuring the post-void residue with an ultrasound is a simple thing. Again, every small hospital will have an ultrasound facility, I guess, and even in the periphery, I'm sure in India, you have access to an ultrasound machine that can measure post-void residue. So something you cannot say that's not possible to do. So practically, if the PVR is high, it means that the patient's retaining, especially over 150, you have to be very, very careful because they're going to get recurrent urinary infections. So they will need some sort of catheterization, either self-intermittent catheterization, which is what we recommend for patients here, is a clean intermittent self-catheterization, or you can sort of have a catheter if that's the only option you have. So I think what I'm trying to highlight in this, which is from the NeuroJet guidelines, is all of this is practical. It is doable. It's just the intention and the interest that is needed. And once you get to this, then you go on to the treatment option. So once you've gone through the basic urinalysis, made sure there's no infection, once you've established if it is storage symptoms, voiding symptoms, or nocturia, then you go towards the management. So in terms of the management, there's non-pharmacological and pharmacotherapy. So for the pharmacotherapy, nocturnal polyuria, there's a good study. There's just one big study, but just one good study with desmopressin. We have published some data on nocturia treatment with melatonin, and people have reported that nocturnal polyuria is very well treated with desmopressin. But if it is just nocturia, even a long-acting levodopa and deep brain stimulation surgery where that was applicable has shown to reduce nocturia in patients with Parkinson's. When it comes to storage symptoms, that's a bit easier, I would say, because you go for antimuscarinics, and there's a list of them I'll come to. There's also the beta-3 agonists and mirabegron, as I mentioned. And avoiding the symptoms, mostly prostate-related, you will use alpha blockers. So this is then, is it sufficient or is it not sufficient? And in UK, I think there's, in Europe as well, there's agreement that you should only refer the patients that need referring to urologists, because otherwise they'll get overwhelmed with every patient with Parkinson's reporting bladder problems. As I mentioned, almost 60% will have some bladder problems. If you refer every patient to urology, then it's not very practical. So there are some non-pharmacological measures, particularly to help with the nighttime frequency and nocturia and prevent falls in patients. So one good advice is to avoid caffeine and alcohol at least 4 hours before bedtime. So we generally say after 3 o'clock, avoid caffeine and alcohol, and maybe don't drink at all. But if you do, then at least don't drink at night. Emptying the bladder before going to bed. It might seem a very simple and straightforward thing to do, but I can tell you a lot of people with Parkinson's, with the complex drug regimes, with all the other problems that they have, might not strike every time. But the point is they need to have a good wee before they go to the bed, and that's something that you can sort of recommend. To reduce the risk of falls, I think the path to the toilet, and sometimes it means involving the family members to make sure that the area is fall safe. We have occupational therapy teams in UK that go and make sure that everybody who has Parkinson's, that their path to the toilet is falls safe. There's rails around and there's well lit, and at night when they walk to the toilet, if you just secure that path, you can prevent 50% of the falls that happen in people with Parkinson's, because more than 50% of the falls are actually at nighttime going to the toilet. And it's very surprising, and I never understand the broad logic to it, but most people with Parkinson's will fall going to the toilet than they would on the road, for example. So because when they go outside and outdoors, they're very careful, people are around them. Well, most people fall when going to the toilet. So just making that area safe can be life-saving for them, but it's important even if they have the safety around, it will be useful because there's nobody else around them at night. In patients with limited mobility but preserved continence, something simple as a bedside commode and flask can help. This is something very basic and simple, but sometimes they don't need to walk to the toilet. Sometimes they can just sit on the bedside and empty themselves. So this is something that is important. Now, in terms of the medication, I'll just summarize these things for you. I'm not going to go into detail of everything, but practically, what is important here to understand is that there's a lot of antimuscarinic drugs that we use. I'm sure most of them are available in India, but they may not be available as transdermal patches or immediate release tablets. But you'll generally get all of these available. What we commonly use, and I'll explain that a bit further to you, is solifenacin, because there was one of the largest studies done in Parkinson's itself using solifenacin. Trospium has advantages I'll tell you more about, but mostly the world has been taken on by mirabegron. So for whatever reasons, mirabegron has become one of the most popular drugs because this is not an antimuscarinic. It doesn't add to a lot of problems and is pretty safe and well tolerated, but there are limitations that I'll tell you about. Desmopressin is available as a nasal spray injections that we can use as well. Usually, the nasal spray is the one that is recommended. Usually 10 milligrams, 10 micrograms nasal spray should be enough. And only use it in patients with nocturnal polyuria once you've documented. So moving on to the anticholinergics, which I think is very, very important. There are two groups, I would say. I mean, obviously, there's oxybutynin, which is the old one. And you know the antimuscarinics have lots of side effects, which is one of the key messages from my talk today, is when you're using antimuscarinic agents, you have to always bear in mind that you're making a cognitive balance worse. So, you know, there's an increased risk of dementia in people taking anticholinergic medication. There's large epidemiological studies saying we should avoid anticholinergics in people with, especially older people. At the same time, you can't do without them, because if you've got bladder problems and you have to use an anticholinergic, then you have to choose one of those. And there's quite a, as I mentioned, there's only one study in Parkinson's disease specifically with solifenacin, which was safe and it was pretty good. But there's not too many studies specifically in this population. But obviously the risk of dementia is higher in people with Parkinson's than in general population. So if antimuscarinics can cause dementia in normal population, I'm sure they will increase the predisposition in Parkinson's even more. But this has not been proven on a case control kind of a study. One of the biggest problems that we face in people with Parkinson's, especially the older people, is polypharmacy. And there's no running away from it, because you can't take off the medication that easily. Because one thing you touch, you just make things worse. So you have to be very, very careful. But you know, there is a thing called anticholinergic burden. And there are drugs that cause high anticholinergic burden, which is measured as more than 15 picomole per liter, moderate anticholinergic burden, and mild anticholinergic burden. So you will be using all of these drugs possibly somewhere in your history, in your practice with patients with Parkinson's. So the common ones, which are often missed, ranitidine, which is mild, temazepam, quetiapine, mirtazapine, fluoxetine, escitalopram, citalopram. They are acceptable. They've got a risk, but what you need to understand is what you will be doing is you'll be adding an anticholinergic on top of them. So for example, if you added solifenacin on top of it, you're actually adding on to the cholinergic burden. The ones that are often hidden in the prescription, especially I've seen quite a few patients in India, the hidden prescription is amitriptyline and nortriptyline. They've got very high anticholinergic burden, as you can see. And I think because they've been prescribed for other things like back pain or neuropathic pain or whatever, they often get ignored, but they've got high anticholinergic burden. So we have to be careful when prescribing another anticholinergic in someone who's taking, let's say, 50 milligrams of amitriptyline. We're adding quite a lot to that burden. Paroxetine, olanzapine, again, commonly used. Oxybutynin is the one, and tolterodine, as you can see here, are the bladder medication that have high and moderate anticholinergic burden in this list. But I think the challenges that are very important is there's all these preparations now, immediate release versus extended release, and you start thinking which one is better for whom. And again, you have interactions with the P450 cytochrome pathway, the liver, and all those interactions, which you have to be careful about. But I think the simple tip here is just look at the drugs, just look at the cholinergic burden, anticholinergic burden, sorry, and then check if your drug that you're going to add is not going to make it worse. Or the better thing to do, which I have done in a few patients, is to take one out and add one in. So if you identify one of these drugs in the prescription that you can replace it with something that has not got anticholinergic burden, then take that one out, replace it, and then add an anticholinergic, so you won't be adding on to the anticholinergic burden. And it's you know, in the cholinergic activity, there's a bladder and brain balance. So at the end of the day, as I said, you can't leave people out and not treat their bladder problems. Sorry. So there are drugs that I mentioned, anticholinergic, and what I want to emphasize is the trospium versus derifenycin and others. So trospium needs active transport, so it is sort of less chances of causing brain cholinergic activity to reduce, whereas the others are sorry, this is I mixed that up. So there's active transport mechanism for derifenycin, trospium, and fesoterodine, whereas there are passive diffusion across the blood-brain barrier with trospium, so it is less likely to penetrate the brain and less likely to cause more problems. So trospium is transmitted through both, but it's mainly passive. So it's unlikely to cause as much of the cholinergic impairment as the others. So trospium is one of the better ones when it comes to anticholinergic burden. Now, of course, these drugs are one part of the situation. Can we do anything else? I think one of the key messages that comes from literature, which is very important to bear in mind, is that men with Parkinson's disease should not undergo prostate surgery because there's a high risk of incontinence. Now, this has come from a study that I've cited below, but I think more importantly, what is important for you to know is that every man who has prostatic hypertrophy with Parkinson's disease, if you say that your bladder problems are going to go away when you have your prostate surgery, you're misleading them, because their bladder problems will not go away with prostate surgery. I think that is a learning that I have acquired for myself, is at least make it clear to them. If they need a prostate surgery, that's a different situation. But if they expect, like other people who don't have Parkinson's, that they'll get a prostate surgery and the bladder symptoms will be fine, that's not true. And they have a high risk of incontinence after that. So if you inform them well, you can sort of save a few people the trouble of going through prostate removals just for the hypertrophy. Obviously, if there's prostate cancer, then you don't have a say in that. There are a lot of people who do botulinum toxin for the detrusor overactivity. This does work in Parkinson's as well. And if you've got specialist centers that are offering this, I wouldn't say no to it. We've got very good specialists here where we work, and we use this quite often. There's been a few studies done on the transcutaneous tibial nerve stimulation. They were safe. There was a change, but it has not reached the levels where you would recommend them for routine clinical practice in Parkinson's disease. But it has been sort of one of the things that people have tried. How this works is obviously the same way that you neuromodulate the onus nucleus and the cells there. And the sacral neuromodulation works in a similar way, safe and effective. This has been shown to be safe and effective in both spinal cord trauma and other kinds of injuries, as well as MS, as well as Parkinson's disease. So these are the two strategies that are used in neurogenic bladder. TTNS has specifically been tested for Parkinson's disease as well, with some promising results, but hasn't got to the point of recommendation. Now, as I mentioned, nighttime symptoms are one of the worst things that happen in people with Parkinson's. So control release preparations can actually help, as I mentioned. Parkinson's comes with a lot of sleep problems, and sometimes it's important to understand that there are other things that can be done to help the sleep per se, because there's something called convenience voids, which is people get up frequently, woken up by the bad dreams or RBD or other symptoms in Parkinson's, and they just have a convenience void. They just go and be them, sort of just for the sake of it. And I think it's very common that people get up at night, they just feel, okay, maybe let me just use this opportunity to go to the toilet. There's been some improvement with pergolide that improves LUTs as well. And melatonin, as I mentioned in our open label study, showed significant improvement in Turia. DBS is helpful as well. I did allude to it earlier that DBS can also improve bladder symptoms. And there's a few studies now. And although DBS was the bladder symptoms were not the reason for doing the DBS, obviously, but in the analysis, they found that actually people were better in the bladder symptoms slightly as well compared to people who didn't get the DBS, or before and after as well. So there's an improvement. So if you're considering somebody who's got the advanced Parkinson's and you're thinking of adjusting their medication, the key tip here is if they're suitable for DBS, if they can afford it, and if everything else is going in their favor, maybe that will help the bladder symptoms, so you don't have to be as aggressive about the bladder symptoms in those people. And if you think they're not getting the nighttime control release preparation, that is another thing to consider. And melatonin can help with sleep, but it can also help with RBD symptoms and also help with nocturia. I'll quickly cover the sexual symptoms. I think it is important to recognize them. And again, in the NeuroJet guidelines, we listed these symptoms as what are the sexual symptoms. Obviously, arousal and erectile dysfunction is one of the commonest things that people report. In females, there's very little study on female sexual dysfunction in Parkinson's disease, but there is emerging literature that is suggesting that it's not just men who struggle with sexual dysfunction, it's also women. And this includes low libido, orgasmic dysfunction, dryness, and dyspareunia or pain. Obviously, the sexual phase is excitement, plateau, orgasm, and resolution. There can be problems at each of these stages with Parkinson's. I'll give you a case-based scenario. There's a 66-year-old man, Parkinson's 5 years ago, has a strained relationship, because this is where it gets very complicated, because with Parkinson's, there's lots of behavioral issues, there's lots of other issues. And then on top of that, if somebody's having significant concerns with erectile dysfunction, it really depresses them. And some people come to us and actually say, this is my only problem. I'm okay with tremors, I'm okay with walking, I'm everything, but this is my biggest problem because this is affecting my relationship and it's affecting my life. So he was on cobeneldopa, rasagiline. He was prescribed sertraline by the GP thinking it will help, but it didn't help and he was very frustrated. So how do we assess sexual dysfunction? I think it's very important at least to ask for it, because I think in a neurological practice, we don't even touch upon this issue. It's very sensitive, there's stigma. And especially in older people, you start thinking, why should they be concerned about sexual function? But that's not true, because if you ask people around, you will understand that people can be sexually active as far as 70s or 80s in their life. So a lot of people may not say it clearly, but they are experiencing problems with it. So if you just ask them, they might just open up. And especially there's a big divide in India and the urban and rural divide, where it's more acceptable to talk about sexual dysfunction in the urban environment. And even older people, 60s and 70s, will open up about it if you ask them, possibly. And I think what is important here is to just understand that this is not due to other factors, and testosterone is a common one. For example, testosterone deficiency is a commonly associated factor, easy to test on the blood tests. Most of the times, there will be other physical factors with Parkinson's that would discourage sexual activity. And of course, there's also confidence issues and behavioral issues. But what is important is if there was pain or bleeding during sexual activity, we cannot ignore that. So I think this is also important. As I said, Parkinson's within it can hide a lot of hidden diagnoses which would be missed if you didn't consider them. And of course, the genital cancers and uterine cancers and cervical cancers, you might just miss them because if nobody talks about them, you never find those things. But this might be apparent only on sexual activity, and they might just say that this is all because of Parkinson's, and it's not. What is very important, as I mentioned, is the psychological factors as well. So when it comes to management, there are lots of things that are available for men. Obviously, there's the three big drugs, sildenafil, varoglutamstat, and tadalafil. I'm sure they're available in India as well, and you possibly are aware of them. But in women, there's not much discussion, but there are vacuum devices and vibrators which can be used, and mainly the dryness is a big problem, so they can be advised that. But obviously, if you can't manage that, you can refer to specialist care. And this is from the NeuroJet guidelines as well. So I'll just summarize the simple wins. So things that you need to refer, for sure, no questions. You don't have to be a specialist, Parkinson's or care of elderly or neurologist. You just refer. And this includes that if there's evidence of urinary tract damage, if there's prostate enlargement, elevated PSA activity, prolapse, hematuria, unexplained pelvic pain, if you've got frequent urinary tract infections that you have sort of more than once, you've treated them, don't sit on them because they will lead to worsening of your Parkinson's patient. So do that quickly. If there are catheter complications, no questions asked, you have to refer them. For sexual symptoms, as I said, pain and bleeding is something that you can't ignore. Pain and ejaculation, priapism, there might be suggestions that there's something else brewing underneath. Suspected hypogonadism or infertility and stuff like that, which will come in younger patients, but not so much in the elderly. I think you can't sit on those symptoms. So simple wins in the clinic, and this is, I think, my last slide, so I'll finish soon, is start the treatment for urinary symptoms early to reduce the risk. One of the key things that I have learned, and you have to possibly you'll understand, is the risk of hypertension in myrobackground. So there's now a guidance, there's a red flag on myrobackground use. This can cause exacerbation of hypertension in some people. So we have recommended within the NHS, there's a recommendation to check the blood pressure and make sure there's no sudden peaks of blood pressure in people who've been started on myrobackground, because that can lead to very severe consequences. So although myrobackground has become the mainstay of everybody with Parkinson's, especially older people, and you can avoid the anticholinergic burden with it, do not ignore the risk of hypertension with myrobackground and be careful in people who are hypertensive. Anticholinergic burden, if I can just say there's one thing from what today's talk is, of course, you possibly understand that is a big problem, but I think replace one with the other is the best. And of course, consider trospium or solifenacin, which have got less chances of causing more problems. Understand the polypharmacy part of the dopaminergic treatment, and amitriptyline, as I mentioned, is a very common culprit. Nocturia can be difficult to manage, but at the same time, I've given you some tips on how to understand this, recognize it, and how you can approach it. Prostate hypertrophy is often a red flag, but if you see it, at least don't recommend surgery straight away, because there's lots of literature saying the success of the prostatic surgery is not as good in people with Parkinson's. And for sexual dysfunction, I think the bottom line for me is understanding whether this is apathy, depression, anxiety, at the same time checking for dopamine dysregulation if there's hypersexuality, but not ignoring that there will be a few people who will really struggle because of this specific symptom. And if you don't ask them, they don't tell you, and everything gets a bit complicated. And they just keep coming back to you and saying, medication is not working, medication is not working, but they don't tell you what is not working because you've not asked them that specific question. And consider simple things if there's possible. This is a source of information, and one of the biggest sources of information is Dr. Jalesh Panikkar, who I work with, and these are some of the publications that we've managed to get together about this in this field, which I think is very important, ignored, but very necessary. And these are my collaborators. Thank you.
Thank you. Thank you, sir, for your wonderful overview and a very practical and pragmatic approach to urogenital dysfunction in patients with Parkinson's disease. So I would request the delegates to put their questions in chat if they have any. So, sir, from the perspective of overactive bladder, from what I understood, you would suggest solifenacin to be the first line medication as per your practice, is it?
That is the evidence-based practice, yes, because that's the only drug that has been properly randomized controlled trial in Parkinson's disease.
So to complete the loop of the initial two patients that you presented, so what exactly happened to them?
Yeah, I actually was hoping to include that at some point. So let me just take you back to them, if I can. I think I'm stopped sharing the slide, so I'll close the loop for you. Just give me a second. So is it okay if I share the slide again?
Yeah, sure.
It's good you asked, Ella. Thank you. So the first one, she had a fall, as I mentioned. So the main problem was nocturia. So that was the main thing that was being missed. So giving her anticholinergics wasn't going to be any help. She had incontinence of urine, but mainly at night. So the way to manage that was mainly getting the history and understanding that this was actually nocturia that was causing her problems. And we treated her, actually, this one we treated with control release 250 already, but we added melatonin, and that helped reduce the nocturia for her. She actually had nocturnal polyuria as well, but it was complicated by the fact that she had hypertension and diabetes as well. And the other one actually turned out to have MSA. He was, as I mentioned, the MSA are more likely to have poor stream and retention of urine. And this is what happened. So although this was almost a 2-year history, but gradually progressed to have all the autonomic symptoms and progressed very quickly. Unfortunately, he's not here anymore. But he progressed to develop more retention, and that is one of the clues, as I mentioned, with the diagnosis of MSA. So my background didn't help any of them. That was the bottom line.
Okay, thank you, sir. And we have a few questions in the chat box as well. Dr. Subhash Kaul wants to know, is there any role of procholinergics in Parkinsonism bladder?
Not in the bladder, but I understand this is coming from the dementia perspective, possibly. And the problem is that actually this wouldn't help the bladder, but it wouldn't make it worse as far as I know as well. So especially in the control doses that we use. So I don't think there's any rule for that. But of course, people are testing rivastigmine and others for falls at night. So of course, this becomes like a complex picture when it comes to Parkinson's and dementia, where you would consider those drugs as well, but not for bladder control, no.
So, sir, to extend the question a little bit further, like muscarinic agonists, like for example, bethanicol in patients, like for example, who have MSA related bladder, not retention, but maybe increased post-void residual urine and poor detrusor contraction.
I would avoid those. There's no evidence at the moment that will support that.
Okay. And Jazz Gurung has a question. They want to know how often do you recommend urodynamic study? And urodynamic study along with bladder and bladder scanning are important for proper diagnosis. So how often do you advise and what is the yield? Like how
All
often
that
does it
helps
like
you.
change management?
Yeah, no, it does help in some cases where you can't. So as I said, it's very easy for me to say you need to find out whether they are storage symptoms or voiding symptoms, but that's not always possible. So sometimes you will get a mixed picture and you won't know whether this is a storage disorder or a voiding disorder, and in which case the urodynamics is really, really helpful. It can tell you about the true overactivity, and particularly the patients where you're thinking of more advanced treatments like Botox, etc. I think I would definitely want to see that and confirm that there's a true overactivity that you'll be treating with Botox. Bladder scanning is a separate thing, and I think I would do that more often, as if possible. I think in most of the neurology clinics and from the MS world, from the Parkinson's world, MSA world. I mean, this should be done in practically everybody who reports bladder problems to make sure they're not retaining. Because if they're retaining and you're not doing anything about it, you're predisposing them for urinary infections. And any neurology patient will get worse if you don't treat their urinary infection. So I think that's like the group. So there's like different answers to the urodynamics versus the bladder, I would say.
So practically, how often do we advise patients for example, something like a clean intermittent self-catheterization, and in a person who is already older and has tremors and other issues with motor function, how practically is it feasible, and what is your experience, sir?
It is very difficult. There's a very nice paper about this from one of our nurses who works in neurology about the practical issues of self-catheterization in people with MS, I think it was, but it also refers to Parkinson's. So I think it was a group of people that she reported. Very difficult, and self-intermittent catheterization does not work for a lot of people with Parkinson's, and that's why I mentioned some of them do need an indwelling or out sort of like external catheter. But external catheter won't help with the retention part of it. So they will need an indwelling catheter. Almost everybody I know with my MSA, the patients that I've seen with MSA in the last few years who had bladder problems will finally go for the suprapubic catheter. That's what we prefer because there's less chances of getting blocked and less chances of infection and stuff, and more practical for the patients as well to manage rather than an indwelling catheter.
That is something that we also find quite difficult in the Indian setting. And of course, because the suprapubic is an invasive procedure that needs to be done by a surgeon, again, the accessibility issues are there. Okay. And we have a question from Piali. They want to know that there are patients in their practice with bladder symptoms without local pathology. And do you evaluate and look out for Parkinsonism? Is it an early marker? And do you follow up for development of Parkinsonism? And does urodynamic study help in this context?
I think I'll just twist that question a bit and say that if there's other autonomic symptoms or not, because if there are other autonomic symptoms like orthostatic hypotension, as you know, there is a condition called pure autonomic failure, which is something that we look at as well. And within that group, almost half of them will convert later to get Parkinsonism. But if this is just bladder symptoms, then you have to look for the neurogenic bladder causes as well, because there can be many other causes for neurogenic bladder. And like you sort of possibly alluded to, the elderly ones, especially if they're females, what you want to make sure is not stress incontinence. The urodynamic studies will help, but at the same time, it will only tell you this is neurogenic bladder if that was the case. But it's not going to tell you the cause for the neurogenic bladder. But if they've got orthostatic hypotension along with it, then it's a different ball game. Then it's a completely different area of work. Yeah.
Yeah. And I think there was a recent publication about the pure autonomic failure and the conversion into some form of Parkinsonism, synucleinopathy, and they are sort of equating it to something like RBD. The risk is quite high.
So the pure autonomic failure is a condition that we know will convert in 50 to 60% people to either Parkinson's disease, MSA, or Lewy body dementia. So one of the synucleinopathies, and we're believing it more and more. There was this group of people called MSA autonomic, as you remember. So there was MSA P, MSA C, and MSA A. So this was, I mean, it's what is clear to me now is not all MSA. Some of them will convert to Parkinson's and some to Lewy body dementia actually directly. So what I mean by that, pure autonomic failure leading on to Lewy body dementia without a clear phase of just Parkinson's disease.
Yeah. And there is one more question. Role of sacral stimulations. Dinesh Saini.
So there is a role, but at the same time, as I mentioned, this is all sort of recent and new. A lot of people are using sacral neuromodulation for neurogenic bladder. There's a strong role for that, but whether this is going to work in Parkinson's or not, I don't know. There's very few people who've had it and very little experience, but theoretically, it should work as the TTNS works as well. So in theory, it should help, but it's still a stage where I can't say with authority that I've tried a lot of patients and it works. So it's a relatively new field for Parkinson's.
So, sir, sacral neuromodulation, would you consider it to be more effective in patients with detrus or hypoactivity or in patients with overactive bladder?
Overactive bladder. So it's the same thing. It will just help modulate that for overactive bladder. So that's what it's used for. So most of the patients with neurogenic bladder will have detrusor overactivity. This is the release of the upper control, isn't it? So if we got like a upper motor neuron kind of a feature. Yeah.
And there is some recent evidence coming from certain follow-up DBS studies that DBS does tend to improve, um not as good as motor improvement, but it does tend to improve the autonomic symptoms as well. So, what is your experience, sir?
Yeah, it does. No doubt. But the point is it improves everything. But as I said, like you realize, if there's so a couple of things I would add there. If it is nocturia and nocturnal polyuria, it wouldn't improve that. So that's something you still have to work out. And if it is voiding dysfunction and retention of urine, it wouldn't improve that. So it will improve the overactive bladder to some extent. There's a similar neuromodulation technique that sort of like settles the outflow from the central to the bladder. So it just helps that. But yeah, it will help with overactive bladder symptoms, but it won't help the nocturia and it won't help the retention.
And any experience with treatment of, like, for example, orthostatic hypotension
No.
in the night
No.
may lead to supine hypertension, and there is a
Okay.
hypothesis that that leads to more.
Yeah.
So,
So
do you
people who
think?
are who
Yeah.
have autonomic dysfunction and get supine hypertension, they're more likely to get nocturia, nocturnal polyuria. So if you treat it, it gets better, no doubt
So,
about
do
that.
you give the nitroglycerin patches and stuff like that?
Not, no. I think we work quite a lot with evidence because in the NHS we have to follow all those things. So off-label prescriptions are not that easy. But I think what helps is, of course, if you control the postural hypotension with midodrine or fludrocortisone, then the bladder symptoms at night will be a bit better as well, if that's your question.
Thank you, sir. Thank you so much. I think Dr. Damija is also here with us, and maybe he can give certain closing remarks.
No, thank you, Ella. I think we are over the time. But thank you, Amit, for a wonderful and a very simplistic approach to the bladder symptoms in Parkinson's patients. And this is one of not only a neglected area, but also consequences of not treating bladder symptoms could be very, very increasing the morbidity and mortality, particularly as we know, the management of advanced Parkinson's disease is a skill. And patients with, say, example, polypharmacy with sepsis, and of course, coming to the hospitalization repeatedly. So we need two things very important from your presentation for resident doctors. That one is that you always rule out sepsis when this patient comes to the hospitalization repeatedly, and second is polypharmacy. So both these things, when they are together, the patient will come with delirium, patient with caudal sensorium, and things like that with confusions, and you always look for either it's a urosepsis or it is the polypharmacy. So it is very important to recognize these and treat them at appropriate time. My only addition would be when I was in Melbourne working with Andrew Hughes for 3 years, and we used to do the sphincter EMG quite often at that time, not only to differentiate MSA and of course the urogenital symptoms in Parkinson, but also to investigate and the autonomic to complete the autonomic dysfunction in Parkinson's. Is that your practice also doing now less and less, or it is? still being used quite frequently.
Yeah, exactly. So that's a practice as well. We do that for the completion of everything and also to understand whether there is denervation. So, like you said, I think the whole idea of trying it for distinguishing Parkinson's symptoms was a bad idea. And what happened was it was very well advertised as the way that you can distinguish PD with MSA. And then somebody said it cannot be used to distinguish Parkinson's from MSA. And then the whole world stopped doing sphincter EMGs, which is, I don't think it was the right thing to do anyway, because it has a role like all the other EMGs that we do. It does give you a very clear pathophysiological link between the symptoms and the pathology. So that's what neurophysiology is for, isn't it? So to give you, without doing the autopsy, you can find out if there's degeneration of the gray cell. So I still feel that is very useful. So thank you for addition, and thank you, Dr. Dameja. Good to see you here as well.
Thank you. I think not only I'm the chair of geriatric neurology at IN, but I'm also chair of the movement disorder at World Federation of Neurorehabilitation. A lot of the rehab physicians and the rehab therapists also are involved in our uh, multidisciplinary practice or in management of Parkinson's disease. So at some stage, we would like to have once again, you being speaking on the same subject in the WFNR webinar, maybe a couple of months from now. So it will be very useful for international audience as has been for our Indian audience. And I can see many senior people in today's webinar, more than 60 people at some stage, and I think people coming and going. So it was very useful. Thanks for your time, much appreciated, and we look forward to see you again.
Thank you both, Hela and
Thanks.
Dr. Dameja.
Thank
And
you.
thank you everyone who
Thank you.
listened and
Thanks.
attended.
Thank you.
Thank you. And thank you, IAN digital team. Thank you. Bye bye.
Thanks.
Have a good day.